Doctor, from the first 20 questions, we need to discuss with you number 9 and number 10 and number 19 and the 20. Number 9. Okay, I switch. Okay, I need to open the document. Sorry, just 1 second, please. First number 9. Number 9, yeah. Abscess and retromolar region is the region who localized around the said molar. Hello.
Of the mandible.
Huh?
Of the mandible. Of mandibular.
Yes, on the mandibular. Yes, around the said molar.
As retromandibular.
Retromandibular. Yeah, it's the same as the synonym. Hello? Yes, doctor, we hear you. Okay. It's about the retromolar region. It's, of course, it's on the lower jaw. It's the same, it's the synonym about retromandibular abscess or the abscess around the said molar, especially when teeth growing. We have you have the question about topographic anatomy. Vestibulary, it's the cheek area, it's the mucous membrane around the said molar. Lingually, it's the distal part, is the pterygomandibular muscle. It's the how it said, it's the pterygomandibular. It's the part of pterygomandibular area because it's localized. It's like the triangle between the distal part of said molar and the distal part of this abscess and phlegmon. About the abscess of this area is the middle pterygoid muscles. Vestibulary is the soft tissues who covering the alveolar process around the said molar. It's not deeper, but it looks clinically, it looks like the pericoronitis. You remember the fourth course when we discuss the teeth growing. And continue like a retromolar abscess. It's the acute purulent pericoronitis. It's the synonym. And then it's continue deeper, closer to middle pterygoid muscles. And the name of this area will be the abscess of retromolar region. Features and the diagnosis and the treatment. The main complaints of the patient is the limitation of the mouth opening, cannot chewing, cannot drinking, and when the patient has the limitation of the mouth opening, we have 3 stages of limitation. If the patient has a 3 millimeter, it's the first degree, or not millimeter, 3 and 4 centimeter, it's the first degree, 2.5, 3 is the second, and around 1 is the third degree of limitation of the mouth opening. How to diagnose? Because it's extraorally, no changes. All changes depends because patient has changes on the function. It doesn't mean no limitation of the mouth opening, pain when the patient eat and drink. And the patient usually know that it happens because the tooth growing, because first symptom is the pain on the mucosa in this area. How to diagnose? We need to diagnose between the acute serous and purulent pericoronitis and between the abscess of retromolar region and between the abscess and phlegmon who localize in the pterygomandibular area. What we use for differential diagnosis? Of course, we use the anamnesis. We need to understand how many days, usually 3 to 5 days, when first symptoms starts in mucosa in the retromolar region. Then continues and change the general condition, the temperature 37 and 2, and change the function. First, patient cannot open for maximum tooth, then it's changes and present delimitation of the mouth opening. Sometimes it's absolutely no movements. Between which diseases we differential diagnosis, again I repeat, is between the acute cirrhosis and purulent pericoronitis, between these diseases, and between abscess of pterygomandibular area. How to understand from anamnesis and from the clinical picture what we can see clinically intraorally. Present the edema and hyperemia, the soft tissues around the tooth. We can see the part of the tooth. It's maybe one tuber on the part of the crown, and how to understand that this process starts with the teeth growing. We need to check on CT scan or on X-ray, OPG or panoramic, to understand the position of the tooth. Usually, if it's not like firstly, and it's not the abscess and phlegmon. It starts with acute cirrhosis and purulent pericoronitis and continue like the abscess of retromolar region. It's the main difference. The ways of spreading infection. The infection can spread to pterygomandibular area, to sublingual area. If it will be deeper, it will be submandibular area. Then, of course, maybe continue. If we discussed is the from the abscess and phlegmon, the floor of the mouth, it can deeper and continue like the abscess, like the phlegmon of the neck, and deeper to the mediastinitis. If it one ways of spreading. Second ways of spreading, it will be from pterygomandibular area, from the pterygomandibular abscess or phlegmon, then is continue and prolonger with the phlegmon of sub of the how to say it it's the phlegmon who localize in the upper jaw. Why we discussed? Because we have two ways. It prolonger or continue with the spreading to the soft tissues maxillary and to the soft tissues of the mandible and deeper to the mediastinitis. How to treat an operation access. Operation access always intraorally, and where will be the flap design? We need to cut the mucous membrane around the causing tooth, and it will be enough that all purulent exudation going from this area to oral cavity. Then we fix the drainage and prescribe the antibacterial, antihistaminical, painkillers, and local anti-inflammatory therapy. Only one problem if we have the abscess of this area, that the patient cannot close the mouth. What we should do if it happens? First, we need to give the anesthesia. It's maybe we can give extraoral, intraoral technique. We prefer intraoral. We give firstly one portion that this local anesthetics like a prevention and helps to relax the muscles. And then the second portion, we use the conductive type of anesthesia to cut the mucosa around the said molar. Very important to understand in which period we can remove the causing tooth. If it's possible to remove in the same time when the patient open the retromolar abscess, it will be perfect. But it depends on the situation, how many space when the patient open the mouth. It's the first. And the second, the position of the tooth. More than 50%, this condition depends on horizontal position of the third molar on the lower jaw. And you know how remove the horizontal position. We can use the flap design. And if we treat the retromolar abscess, very important first to open that's the purulent exudation going from this area and like open the crown. Second period will be when we understand that enough space inside to remove the causing tooth. We did it in the same time. About the general condition suffering, of course, and the patient has headache, pain, temperature about 37 and 4, 37 and 6, and usually we prescribe antibacterial therapy for this case for 7 days or 10. The same antihistaminical treatment for 7 to 10 days and local anti-inflammatory therapy. That's all about the answer of retromolar region.
Doctor?
Yes?
What is the difference between question number 7 and the question number 8? It's the same or not?
Sublingual area, it's absolutely different. Sublingual, where is the area? It's the part of low of the mouth. Think.
Doctor, but in question number 7, this abscess.
Yeah, they are both sublingual. But one of them is talking about the phlegmon and one of them is talking about
the retromolar region. It's absolutely different area. Retromolar, it's the distally.
Doctor.
No, you don't understand this. You are asking about the difference between question number 7 and question number 8. They are both talking about the sublingual area. One of them talks about the abscess and the other phlegmon.
Yes. First abscess, second phlegmon. Different clinically, clinically, and the different from the blood analysis and the different about the treatment plan. Abscess is localized, phlegmon is diffuse, inflammatory process. Abscess and phlegmon were of course treated in maxillofacial region, in the department of maxillofacial region. Abscess, you can palpate, infiltrate. You feel it under the tongue, under the finger. In the phlegmon, it's the clinician, more symptoms, more hyperemia, more temperature, more change the function, because patient cannot moving the tongue. Patient with open mouth, tongue change the position. It's higher than the occlusal part of the teeth. And the same topographic anatomy, difference only clinical symptoms. And the general condition, of course, on the general condition, phlegmon suffering more. I mean, if we discuss abscess on phlegmon is more changes generally. And the treatment in abscess, we prescribe only antibacterial, antihistaminical, yes, antibacterial, desensitization, and painkillers. Of course, open the flap to open the purulent exudation, purulent infiltrate, to open the infiltrate, and local anti-inflammatory therapy. In phlegmon, we another one part of the general treatment, not only antibacterial, and we prescribe desintoxication, because general desintoxication therapy, because the general condition suffering more than in abscess. And of course, abscess, it's only abscess. Phlegmon has more chances for spreading the infection, because the time of the disease is more. Phlegmon abscess, it's about 3 to 4 days. Phlegmon, it's about 5 to 7, usually 1 week or 10 days. The time of disease is different, the general condition different, the clinical picture different. In phlegmon, it's more danger. I mean, more hyperemia, more pain, more change the function, more change the position of the tongue. Of course, lymphadenitis, the same, will be more changes. And the general condition, of course, patient cannot eat, cannot drink. And in the operative access, the same, different only the treatment. Again, repeat, in abscess, we prescribe antibacterial, antihistaminical, painkillers, local anti-inflammatory therapy. In the phlegmon, we prescribe antibacterial desintoxication. We need to decrease the level of infection from the general body. Then antihistaminical treatment, and then local anti-inflammatory therapy. And in phlegmon, we prescribe physiotherapy. In abscess, we how said in English? We don't use the physiotherapy in abscess. We prefer physiotherapy on phlegmon. This is the difference. Understand it?
Yeah.
Yes, we understand. What about the surgical approach to treat an abscess and a phlegmon? Is it the same? Surgical approach?
Yes.
The incision, it is the same for an abscess or a phlegmon?
Yes.
Okay.
It's the same. Absolutely the same.
Okay.
You remember how we cut the sublingual? We use the inner part of the mandibular. We put the scalpel perpendicular to the bone and cut the mucosa and submucosa and periosteum. Then we use respirator to go in deeper. We don't cut like this. We cut like this. This is the jaw, and we put the scalpel horizontally, not vertically. Understand what I mean?
Yes.
Because we need to feel the scalpel. It's very important. If we use parallel access and we can use the vertical incision, it doesn't mean that you can penetrate the nerves and the general artery. You remember, it's the lingual nerve and lingual artery. We cut only the mucosa and submucosa and the periosteum from the lingual side of the part of the mandible, from usually from third molar to second or to first premolar. The length of access will be around 4.5 or 5 centimeter for full. Then we separate the soft tissue from the bone and open it, and if was the right technique, you can see the purulent exudation immediately from the access. Then we irrigate it and put the drainage. We don't suture the drainage. Sometimes it will be possible, but usually no, because patient cannot move good the tongue like in the health situation. Because now all muscles and in sublingual area and the soft tissues and with the contact with the purulent exudation and change the function. Yes, please.
Doctor. About the abscess is a number question. Abscess and the phlegmon localized in the tissue adjacent to the upper jaw. Which type of adjacent to the upper jaw we should talk about?
Yes, you need to know to understand only the name of the spaces, and that's all. No special answer for this, because if we can discuss all, it will be very long answer. You need to know how many spaces localized to the area, to the maxillary area, to the mandibular area, and from what the number of the teeth, who start to produce the abscess and phlegmon on this area. This one.
Like for
the canine.
Mm-hmm.
Yes, for you answer a zygomatic area. Yeah, for example.
Okay.
I can ask how we intergenic reason for this area. Firstly, no. We have how said, not firstly, primary and secondary reason of abscess and phlegmon. Stomatological, odontogenic. Symptomological, it doesn't mean, for example, if we discuss infraorbital area, tooth will be the reason, primary, and secondary, it will be like a reason of the local action. For example, when we use infraorbital anesthesia, this is the reason of abscess and phlegmon 2 on this reason, but it's not primary from the causing tooth. Understand what I mean?
Yes, doctor.
Because we'll start like odontogenic first primary. I mean, it doesn't mean that we need to know the number of the tooth from canine to second premolar. You know it, yes, from the literature. But for example, you want to treat the pulpitis. You give the anesthesia. The anesthesia, you forgot about the probe and penetrate the blood vessels and stimulate the hematoma on this area. And the hematoma can treat it's possible to treat conservative, or maybe it will be surgical. Hematoma transformation to the abscess on this area and to the phlegmons. It's not the odontogenic area, but the reason of this area, of the inflammation on this area. But the action of stomatologist stimulates the hematoma stimulates the inflammation, and we have the infraorbital abscess and phlegmon. Understand what I mean?
Yes.
It's from the classification, because we have odontogenic, non-odontogenic. We don't discuss the specific because we have, if you remember from the last semester, from the fourth course, that we have the specific diseases, and specific diseases, for example, actinomycosis. We have and phlegmon, but it's specific, but we don't discuss it. Okay, next one.
Next one, number 18.
يا جماعة لسه في 13 كنت عايز أسأل.
Detoxification therapy, you mean?
No.
19.
One of the
Infection.
we talk about
Detoxification, yes, 19 years. Yes, 19.
18 كنا.
Detoxification therapy.
18, doctor,
Detoxification
18.
therapy.
18.
The necrotic phlegmon of the bottom of the oral cavity, clinic principle and the course of anaerobic phlegmon. It will be the same localization. It will be the same clinical picture, different only in one. If we discussed only aerobic phlegmon, you know, it's Staphylococcus, Streptococcus, but we have anaerobic infection. What's the difference between? Clinically, we have very short period of full clinical symptoms like for phlegmon. It's very short period. If it's standard period, it's about 5 to 7 days. If anaerobic infection, it's 3 to 4 days, and we have full clinical picture of phlegmon. What will be the general clinical symptom? When you palpate the area, you feel like bubbles under the tongue, because you know that anaerobic microflora stimulates the gas. It's like the product, it's the toxins, and these toxins localized in soft tissues, and when you palpate this area, you feel like a crepitation, like a sound, like a snow under the finger. You know the sound of the snow. You go to the by the snow, by the foot, on foot, and you see the sounds. It's the same sounds, or sounds like bubbles between the soft tissues, and the difference will be only in blood analysis. We have bigger level of C proteins, bigger level of the leukocytosis. It's more than 40 leukocytosis. C reactive proteins will be 25, 30. It's too big. It's really big. And change the ROE is the speed of erythrocytes, how it in English, normally 2 to 6. There we have about 15, 18, 20. It's too big. This is only clinical symptoms. Clinically, we have the same symptom like a phlegmons, standard phlegmons. General principle, general difference between anaerobic and aerobic is when you palpate the area, you feel the crepitation under your fingers, like a crepitation inside the soft tissues. And the very big difference you can find in blood analysis about the C proteins, C-reactive proteins, and the leukocytosis. On the treatment. First is the desintoxication therapy. Second one, it's not typically antibacterial therapy. We choose the antibacterial therapy who fight with anaerobic microorganisms. How to understand which type of anaerobic microorganism stimulates this inflammation? When you cut, the treatment plan surgical the same. You need to cut. You have the purulent exudation the same, but with the purulent exudation, you feel the crepitation. You take the pus with sterile part, fix inside, and go this test to microbiological laboratory. They answer. They need to analyze which the type of of microorganisms stimulates this inflammation, and give you after 48 hours the answer about which type of antibacterial therapy we need to use. But we cannot wait 2 days. We prescribe massive antibacterial therapy. It's about 3 different names of antibacterial therapy. I mean, it will be penicillins, 100%. It will be cephalosporins, 100%. And one more, maybe it's the macrolides, or maybe hinolones from the group of hinolones who fight with anaerobic microflora.
Doctor,
this is the difference.
It's written about anaerobic,
yes.
Like metronidazole.
Metronidazole, yeah. We use this metronidazole like the intravenosis infusion, and we summer it with desintoxication therapy, and we use the solution of ringers and infuse the solution of ringers with metronidazole, and gives the patient intravenosis 2 times a day usually. We start it in the same day of the day of operation. For example, we open on Monday. We start the same on Monday, 2 or 3 antibacterial therapy and the metronidazole. Yes.
And anti-gangrenosis? No?
Where is it?
Like to recommend for this.
Anti-gangrenose, where is you? Anti-gangrenose, what do you mean?
To give to the patient for this case.
The result of anaerobic phlegmon, it's the huge necrosis of soft tissues, because the action of anaerobic microflora is the huge destroyed the proteins. You know that the cells consist of proteins, and the muscles consist of proteins more than 55%. It's the fibers of the muscles. And the anaerobic microflora eating, because it's like they eat by the blood, because they eat blood cells, and they produce themselves, when the replication of anaerobic microflora, they stimulate the toxins. This is the result of action of anaerobic microflora. These toxins absolutely destroy the proteins and stimulate immediately necrosis. And the very big problem, if we discuss the phlegmon, it's not prefer, it's more than if present the anaerobic microflora, that we need to cut more dead necrotic tissues in the area of inflammation. This is the problem because we have a huge defect and we need to use the elements of plastic closure, the big defect, and this is the big problem because we cannot use in the same time the plastic part for covering the defect zone because anaerobic microflora is very active and very aggressive, and we need ways and using the plastic elements to closure the defect when finished the huge inflammation.
Doctor, about the question number 13, they ask for buccal and prepharyngeal and pterygoid spaces. Pterygoid spaces here we mean the question means that pterygomaxillary, pterygomandibular, and or which one?
A medial pterygoid space. We have pterygoid too, medial and the distal, because we have two pterygoid muscles, one medial, one distal. We discussed in this buccal, peripharyngeal, and pterygoid, medial pterygoid area, not distal, not horizontal, vertically.
Doctor.
Yes.
Doctor, if you have a phlegmon in the floor of the mouth, we have a sublingual and submandibular. How it will be the axis?
Two sublingual. No, we have 5 regions because we have 2 floors, superficial and deep, or first and the second floor. 2 sublinguals area, one left, one right. 2 submandibular areas, one left, one right, and 1 submental. This is the floor of the mouth. How to open it? We can use only extraoral access. We use the cut from angle to angle. The cut will be parallel to the distal part of the mandibula, and you palpate this area, it will be first part. And the part of the cutting will be deeper to 2 centimeters, but the direction of the flap will be parallel to the low part of the mandible. And the submental area, we can use vertical access. The access from one side to other side, huge. We cut the skin. We cut the fat layers. We cut you remember that this is the the muscles of the gastricus 2 parts. We cut it. Then we can use deeper because we need to open submandibular and sublingual areas and 1 submental. And does it mean that we have huge access? The same, we separate and drainage these 5 areas, 2 sublingual, 2 submandibular, 1 submental, and if it's full floor of the mouth, the diagonals of the floor mouth, we can use if 2 or more spaces from the anatomical area of floor of the mouth was under the inflammation. What does it mean? For example, we have the patient has 2 areas, one submandibular from the right side. The full diagnosis will be phlegmon on the floor of the mouth. If patient has inflammatory process in submandibular right and submandibular left, it will be the same phlegmon of floor of the mouth. Understand what I mean?
Yes, doctor, I understand.
If the patient,
I mean,
if the okay,
I mean, if it's
Okay.
in just, for example, a right side, we have sublingual and the right side submandibular, how the access will be?
Access will be extraorally. The same, it's like not full the parts of the right side. It's like you open submandibular area. The flap design will be like you opened submandibular area, but you drainage submandibular area and going distally and deeper to drainage the sublingual area. One access extraorally. No two access, one intraorally, one extraorally. We open extraorally.
Doctor, next question please. 19 detoxification.
طب استنى على انا كنت خلف 15.
15 هديهولك
Это
انا.
я не понимаю. 15 это что такое?
15.
Окей.
يا عم هديهولك انا 15.
Okay. Therapy is a desintoxication therapy. I have a mistake. Detoxification, a desintoxication therapy. You can read it in the information from the general treatment of abscess and phlegmon. You have like this information, it will be enough. You need to know the name of the solution and the reason why we prefer. I mean, the action of desintoxication therapy. We have three big reasons why we use the desintoxication therapy. You have this you have this inflammation. Oh, you have this you have this information from the portal I downloaded. I repeat it. Okay, we have one. One is the we need to start the market circulation. If the patient has phlegmon, all function of the blood changes. What does it mean? Patient don't eat, don't drink, and the viscosity of the blood will be higher because not enough, not water, but not enough solution for a normal market circulation. First reason. Second reason, we use the solution, and why we use the solution for desintoxication therapy. We need to stimulate the renals. That toxins area, toxicity area, the level of toxicity will be lower because the desintoxication therapy stimulates the market circulation, stimulates the function of the renals, and stimulation the stimulation the normal action between the microorganism and the level of products of their life. Can eat. You understand why? Yes, the limitation of the mouse, opening temperature, patient, and we intravenous. We use the intravenous infusion for stimulate the macrocirculation to decrease the level of toxicity and to change and normalization the function of the renals and the heart. If you remember, if the viscosity of the blood changes, what happened with the blood pressure, guys?
Hypertension.
What happened with the yes. How to fight hypertension? We need to change the viscosity of the blood. We save the normal pressure. Yes, we change. Because if viscosity is so high, pressure is the heart is the muscles. Muscles need to use more pressure to stimulate the blood circulation. This is the reason why we use the desintoxication therapy. This is the reason. And And what solution use? We can use the Ringer solution with glucose and vitamin C. We can use the physiological solution, the same with glucose and vitamin C. And we have a special solution. We don't discuss it because you don't have a special lecture for this, but it depends on the general condition and the test and the blood analysis test, the result of it. This is the area, this is the reason why we have many steps of desintoxication therapy, but we choose, and the type of desintoxication therapy depends on the general condition of the patient. For desintoxication therapy, we can use the hyperbaric oxygenation, hyper HBO. What is it? It's a special camera with the oxygen, and the patient with phlegmons, with the complications after phlegmons, need a normal oxygen, как сказать, кислородный обмен, oxygen nutrition. And if the patient has systemic inflammation, and phlegmon is a systemic inflammation, how to help the patient? We need to give the patient more oxygen. This is the part, hyperbaric oxygenation. It's a special part of physiotherapy. But it's systemic physiotherapy. It's not locally when we use the laser to skin, yes, to stimulate the microcirculation. This is the special pressure inside the big camera when the full body with, the patient full going deeper to this camera and change the pressure with oxygen. And this helps the patient to stimulate the normal oxygenation and decrease the level of toxicity from the main organism. And this is the part of desintoxication therapy too. You need to know why we use the desintoxication therapy. Some names of the desintoxication solution, and if you remember to exam about hyperbaric oxygenation, HBO therapy, it will be perfect. For answer, it will be enough. But basis on this desintoxication therapy depends on the level of toxicity, and the level of toxicity depends on the result of changes in the blood test. Understand?
Yes, doctor.
Yes,
doctor, question 18 of
Yep.
the proliferative nephrotic. It is written in.
We discussed it 5 minutes ago, before.
15, doctor.
Number?
15. But not.
15.
No.
Yep. No. One of the eye, topographic anatomy. Topographic anatomy. It's the same, not primary odontogenic reason. It will be only secondary not secondary odontogenic. It's not primary reason because it's not depends on the. We don't have the contact with the teeth of the upper jaw, but it may be like a spreading of infection from the infraorbital, from the zygomatic area, and from the temporal area, temporal space. Why we discussed it? Because sometimes the patient looks like after the fracture, the eye changed the position. It's the exophthalm, because the eye is like a bigger, it's like more superficially than from the normal. Patient cannot movement of the eye. And the big problem that patient can lost the eye, because if the purulent exudation localized in how it in English, I need to remember how it in Russian. Retrobulbarная клетчатка in the fat areas, retrobulbar, when the ophthalmicus nerve penetrate the eye. This is the fat here in orbit This is the muscles who controls the action, the movements of the eye. The big problem that we can lose the eye and the infection spreading straightly inside the brain, and the patient has which name of complication? Who can answer?
Meningitis, doctor.
Meningitis, yes. Meningitis.
Sinus thrombosis.
It's the reason of spreading infection from orbit, from retrobulbar, yes, tissues. How to open it? We have two access. We can use the low eyelid, or we can use the not distal. We can use the not medial here, not superficial. We can use the first access. We can use. We need to palpate the eyelid of the eye. We can palpate it, and from this line, we use. We need to use the space deeper. About 3 to 5 millimeters, and it will be like the eyelid lines, the excess. We cut the skin, we cut the fat, and going deeper under the eye. It's the first access, and the second access when we use zygomatic arch. Use orbital and zygomatic part here.
The edge of the eyebrows.
Yes, eyebrows. Yes, I forgot the name of this anatomical eyebrows. Yes, thank you so much. We use this, and we can use the access the same. What the difference? If the patient has purulent exudation deeper under the eye, I mean in the low part of the eye, closer to the infraorbital area, patient feel that the eye changed the position. It's like the exophthalmos. And if the purulent exudation localized upper, it's the eye. This is nerve ophthalmicus. If it's localized this, it will be that's the eye changed the position. It will be closer to the superficially. If the purulent exudation localized here, what happened? Patient cannot move the eye, because if you remember how muscles touch and what the muscles stimulate the movement of the eye, it's more here, and
about
the patient cannot move. And yes, if a patient can see only straight, understand what I mean? And if it's localized deeper and superficially from the nervus ophthalmicus, patient feel view. What does it mean? It's like a diplopia. Patient feel twice object on the eye of causing area and normal from the normal side. Understand what I mean? Different view, because we see the same picture. Yes, it doesn't matter. 1, 2, both. If the patient has problem with the eyes, patient see twice. It's not one, twice part, twice subjects. How is it? 2, not one apple like two apples. Understand what I mean? This is the symptom of diplopia. Diplopia. Yes.
Doctor, about
Next
question about the complication. It's like the whole lecture, the material about the
yes, you need that we have the complication of thrombophlebitis, sinus thrombosis, and mediastinitis and sepsis. You have in examination card 1, for example, complication of abscess and phlegmon, thrombophlebitis. Next,
just one from them.
Complication of abscess and phlegmon, sinus thrombosis.
Not all of them.
Not, of course, not all. We have one question, but in the examination card, it will be separate by one. Yeah. Yes.
Okay. Thank you.
Doctor, which of the questions will not be in the exam? Did you delete something or no?
Now will be all.
Okay.
Doctor, can you...
35. Drug therapy, drug that affects bone metabolism, physiotherapy for fracture of the jaw.
We discussed it about the drug therapy. What does it mean, drug therapy? If we have the fractures of the jaw, we need to prescribe. Yes, we have straight recommendation. We need to use antibacterial therapy, desintoxication therapy, antihistamine therapy, and local anti-inflammatory therapy. If antihistaminical and desintoxication therapy will be the same like it was in inflammatory process, antibacterial therapy will be different, because if we remember the action of antibacterial therapy and of antibiotics, we have two groups. Сейчас я скажу. Just a second, please. It's the two groups. One, как сказать, забыла по-русски слово. Сейчас. We have two groups who kills the microbes and who stops the produce microbes. How it in English?
Bacteriostatic and bacterio.
Thank you so much.
Bacteriostatic and bacteriostatic.
Yes. We prefer in fractures bacteriostatic, because the jaw has lower level of of microcirculation, and bacteriostatic will be enough to stop the inflammation. This first reason. And second reason, from classification of antibacterial therapy, we use the antibiotics who сейчас я скажу, who has cells inside the bone structures. What does it mean? Who accumulation the effect to the heart structures. If we discuss antibacterial therapy in inflammatory process, abscess and phlegmon, we prefer that the cells of action of the antibacterial therapy will be in the soft tissues, in parenchymal organs. If we discuss the fracture, if we use the same antibacterial therapy like we use for abscess and phlegmon, we don't have enough effect. Why we prefer the antibacterial therapy who can work in hard structures? We have only two, penicillins and macrolides third generation. What we prefer? If the patient has allergy reaction for this antibiotics group, we use two from the different groups. We can use cephalosporins, for example, and hinolones. Understand what I mean? This is the difference between the drug therapy. And it does mean that the drugs that affect bone metabolism. It's the first step, first stage. Second stage, when finished the inflammatory process. When finished the inflammation, we use a second part of drug therapy. We can use systemic medicine who stimulates the bone regeneration. We prescribe the calcium and vitamin D3 for stimulation the osteogenesis. Understand what I mean?
Yes, doctor.
Unfortunately, we cannot use it together with the antibacterial therapy because it's the antagonism. If we use 2-in-1, it doesn't mean that the level will be lower than normally. Why we use two-stage of drug therapy? First, we need to decrease the decrease, yes. We need to decrease the inflammation. And second stage, we need to help the patient, to help the bone to regenerate. This we use only the calcium and vitamin D3. How many days? If for fracture we prefer antibacterial therapy for 14 days, it's about 1.5 to 2 weeks. It depends. Single type of fracture, closure type of fracture, one side, two side, using the osteosynthesis or using only this splinting technique. Then we wait 1 week and we start when finished. For example, we prescribe for 2 weeks. Then we wait 1 week and prescribe for 1 month the drugs with the medicine with the calcium and with vitamin D3.
But
Yes,
doctor,
vitamin therapy for 1.
We don't give the bisphosphonates, what we give in
Of course, no, we don't give it. Bisphosphonates kills the bone cells. Bisphosphonates finish the macro circulation because bisphosphonates has cells inside the bone who dead the bone cells. If the bone cells dead, the bone structure will harder. Bisphosphonates we prescribe only if the patient has osteoporosis third and second degree. It's not growing the bone cells. It dead the cells. The effect of this medicine is the finish the nutrition. You know that we have 2 cells of osteoblast and osteoclast. One is function destroys the bone. Second function, or the function of the second one, it's the creates the new bone cells. What's the effect of bisphosphonates? They kills the cells who has produced the bone. Understand it? Why we discuss that it's like the dead bone. It's not the dead, it's not like a necrosis. It looks like harder, but no macro circulation and no cells who can produce new bone.
Regenerate, okay.
Understand?
Yes.
Yes. Physiotherapy for fracture of the jaws, we discussed. We can use the laser. We can use, usually we use the laser and it will be enough because we stimulate the same macro circulation. And the general idea of fracture treatment or the treatment of fractures bone is the reposition to the right position and fix to the right position. This is ideally treatment for fractured.
Doctor,
Yes. Yes.
question number 27 and 29.
We discussed it. Clinical characteristic of mandibular fractures. Single from the both side, near to the mental, near to the angle. This is the typical fracture side. We discussed where is it?
Just like
In the mental.
classification.
Now the characteristic. You have the clinical characteristic of mandibular fracture depends on the localization. What does it mean? If the fracture localized from one side of the jaw and the fractured line through to the mental foramen, how many fractured bone we have? Parts.
Three fragments, doctor. Two fragments.
Two. One small, one big. How patient look extraorally? What about the bite? Is the clinical characteristic. Direction, fractured bone change the position from the normal. It depends on the muscles. You remember it. If we have from the both sides of mental, from right, we have three fractured parts. One central, one right, one left. Central part, change the direction, will be distally and change the direction distally and higher or lower.
Downward.
Down, low, down. And what happened with two fractured parts? I mean, one buckle this, one buckle this. They change the direction like this. Understand why? Because no central line, no muscles who control the central part, because the central part is broken. And this part change the direction. They change from this like this. Understand what I mean? What you can see clinically. Patient cannot close the mouth. Patient has opened the mouth because central part of the fracture change the direction, has distally and deeper. What happened with the tongue? Tongue changed the direction too. Understand it? Why? If we don't have control, we don't have the muscle control who has connection with the, what's the name of the bone, thin bone, like this. I hide it. Yes, that's right. They constrict immediately, change the direction. And what happened with this? This changed like this one. More buccally, more distally. Understand why? Because the muscle who control this area change the direction too. Because the muscle who control the central change the position. How patient look? You need to know how the patient look. You don't discuss about all fractured clinical characteristics. Typical fracture side. How many sides we have? From the mental foramen, from one side, from the both side, from retromandibular or angle is the same. From one side, from both sides. And we typically fractured line in the TMG. Which part of TMG usually broken?
Condylar process.
Condylar process.
Condylar process, yes. How looks the patient with the fracture of the condylar process? The jaw changed the position in which direction? In direction or in fractured line? Where the jaw changed position? Change
To the fracture.
Cannot open, cannot close. Yes? First, then patient cannot move from side to side. Then jaw change slightly to the healthy side. What we can see else? What about the part right and the left? How patient looks superficially? When you see the
asymmetrical.
Patient, because you think that the fractured line has the size smaller, shorter length will be there, like the normal, because change the position of the mandible. How to understand it? Usually we can understand only on X-ray, because if you remember the pressure we discussed, yes, we have the symptom of the pressure. when we give to understand where is the line of the fracture. If we give the pressure here, where will be immediately pain? In the term G. Because when you give the pressure, yes, here the pressure and the power localize here to the ramus and to the temporomandibular joint area. And of course, we can use the X-ray to understand where is the level. How to treat the patient with this localization, with this fracture localization. We can use osteosynthesis. We can use long pass. We can use the osteosynthesis. Or if it's possible, we can use the endoscopic procedure to fix their part to the right position. Of course, the splinting, because it's conservative. Here, if the patient has the fracture of the condylar process, we can use the combination. In 99%, the condylar process changed the direction. It does it mean? What's the name of this fracture? What the name? With?
Again, please, doctor.
We need what we should. In 90%, the fracture of the condylar process. What's the full name of the fracture? We have classification. Yes, we have one classification is the traumatic injuries, pathological injuries. It's traumatic, for example. Then it's closure or open type of fracture.
Closure. Close, doctor.
Closure. The next one classification, the name?
Combined.
Closed and opened and combined, communicated, compound, and after that pathologic, and after that the.
What is the name of fracture when the fracture change, when the fractured bone change the position?
Rotation?
Open or
Rotation?
close?
Oh, no.
No.
Dislocation?
What the name of fracture? If the fractured bone change the position. Open or close?
Open traumatic fracture?
If the fracture bone change position, what is the full name? Sorry, can you repeat? I don't hear it clearly.
Dysfunction?
Found the doctor. I'm sure.
Open intraoral.
No, we don't have open intraoral or extra open.
Open with displacement?
With displacement, thanks God, yes. It will be always with displacement. And the treatment of this fracture is always conservative and surgical. Understand it? Yes, continue, please.
Question number 29, doctor.
29.
What does it mean? Orthopedic methods of treatment. It's conservative treatment with splinting technique. Or when we use the special surgical therapy that we use, it's the name of this surgical technique. Господи, как он по-русски называется? Внеочаговый остеосинтез. When we use a special system of construction, one part of construction we localize, we use these methods when we have distraction, when we have multiply zone of fracture, and we have small pieces of the bone. And unfortunately, these small pieces we cannot reposit to the right position and fix. And in some cases, we needed to remove it. And after removing, we have a defect. We can use a special technique, and this technique consists of how it said, of a special laboratory type. We have one. It's the like osteosynthesis. We fix this as with a special screw. It's like how it said, like expander inside, and we have a key. We use we fix to the fractured part of this. I don't know how it said, apparat fixator. We fix it with a screw to the bone, and then we have a key. If you remember the general medicine, and if you remember how they treat the fractured leg or arms when we have many parts of fractured line, we use it. It looks like a shashlik, sorry for understanding, and we have two parts who has connection with the bone, and one part is maybe localized extraorally, maybe localized intraorally, and the surgeon has a special screw. Every 3 to 5 days, it depends on the full construction, we rotate with a special screw. It's like a key lock, and it's like, it looks like a it looks like a key, and I don't know how it is. It's like a key. You put it and rotate, and this expander inside decrease the length. It's like bone regeneration with a special technique laboratory preparing, and the name is like apparat Elizarova. I don't know how it in English. Apparat Elizarova. Elizarova is the same methods like we treat the fractured leg or the fractured line, arms. Sorry. How to create this? We use the MRI, scanning the fractured part.
Doctor,
Create, yes, and create
this technique was about the system of the splinting, or like applying tires, or which one?
This is like osteosynthesis. But
so the question asked about, I think, a splint and applying tires technique.
Yes.
Doctor, where we can find information about this? Because in lectures we don't have information about this question, about standard ribbon and wire tires. What's this?
Okay, I check it, but I download the treatment about the upper jaw. You have the information. I check what you need, and I download today.
Ask here, doctor, about this question, and like we will have the answer here.
Yes. Okay.
Okay.
Just 1 minute, doctor, please. How we hear answer about osteosynthesis if we write like orthopedic treatment, like splints only, and the osteosynthesis like surgically?
No, conservative treatment, it always treatment when we use the splint technique and splint fix on the teeth. If we use orthopedic and surgical treatment, it always we use osteosynthesis or special methods of surgical treatment. When we use, we can use the splint technique too, but the splint on the jaw bone, not on the teeth. Conservative is on splinting, but this is the part of conservative orthopedic. Understand what I mean?
Okay, doctor. This question, how can I answer on this the parts of the question? The first part is a system of bent and wire tires and the indication of use and technique and standard ribbon and laboratory. How can I answer in the parts? Each part.
Where you was 5 minutes. The guys we discuss, I write and download.
Okay. Mm-hmm.
Doctor, it's like about osteosciences. We were talking about osteosciences only.
Yes.
Doctor?
Yes.
What is the compression distraction?
This is the same what I mean, compression distraction.
This
is the orthopedic surgical treatment when we use special methods for fixing the broken jaw parts, and we have intraoral part and extraoral part of this compressive distraction osteosynthesis. What does it mean, distraction of the compressive? We fix to the one direction all fractured bones, but we have a defect. It looks like a meat, like a shashlik on the one part. This is intraoral. Extraoral, we have a special key or special lock to unscrewing and destroy the fractured bone to create a new bone because we have a defect. We use a special key, and inside it looks like okay, I downloaded it. It's impossible to understand it now when you see it on the picture.
Okay, doctor. Okay, thank you.
Yes, next one.
36.
We can discuss each questions, yes?
Not each question. I just want a part of the 36.
This information you can find on portal. I download this information, how to treat the middle zone.
Okay, doctor, I understood it, but just which methods of the hanging of the intact bones of the cerebral skull?
You can find all methods, what you need from the information on portal.
Okay, doctor, about the future of care of the medical and physical treatment of the wounded, the jaw diet, and the type of the probe feeding methodology, these things about the 38.
Yes, we discussed it on the practical class. Why we need to discuss this? Of course, if the patient has fractured the bones, patient has conservative or surgical part. This part localized inside, and we have always splinting, two jaws, up and low in the normal occlusion. Of course, patient and it cannot open. Patient cannot open the mouth because they fixed together up and the lower jaw. How to patient eat and clean?
Intravenous.
Yes, it's impossible normally. Now, of course, we have a special electronic devices for orthodontical therapy. You know, for the bracket system, we have a small head of the toothbrush, and you can see the patient can clean it. But what we should do if the patient, they can clean only superficially, cannot clean inside. We prescribe the antiseptic irrigation for the patient, how the patient can do this. And we prescribe 2 to 3 times a day toothbrushing, but it's only buccal part of the teeth can brush. What we can recommend else? If patient after 4 weeks, we know that the patient possible to open, and we have on X-ray that we have positive result. Patient has normal regeneration in the jaws fractures side. What we recommend? We recommend oral hygiene, professional oral hygiene, because you imagine for 4 or 5 weeks, patient cannot clean lingual part or palatal part of the teeth. How many plaque will be there? Who knows? At first, it's about the care. What about the medical and physical treatment, the ones in the maxillofacial area. Medical, what we prescribe, it's not it's not the systemic antibacterial, antihistaminical, it's only locally. It does mean antiseptic irrigation if the patient has suture inside application with the past with antiseptic effect. And physical treatment, we discussed that first 5 to 7 days will be inflammatory reaction in the part of the fractured bones. What do you think? In which from which day we can discuss with the physiotherapist from the physiotherapy department, doctors, that we can prescribe the physiotherapy? If we discuss abscess and phlegmons, we prescribe when we open it after 2 to 3 days, yes, as soon as possible. In the fractured bones, the same situation, but very important to fix the jaw in right position. If you only reposit and it's first, but you cannot using because patient lost the teeth, if we discuss about the conservative therapy and we're planning the surgical therapy, we prescribe the physiotherapy when will be the osteosynthesis, after osteosynthesis from 5 to 7 days, because it's operation. Operation has the same inflammation time, and the inflammation time bigger than we only cut something, yes, and open. And then we discussed with the doctor from physiotherapy department after 5 to 7 days after osteosynthesis that we can prescribe the physiotherapy. Usually we prescribe the laser. In some literature, you can find that you can use ultra high frequent of electricity with the calcium or with the magnesium. It's like plastin who fix with the special solution, switch on, and the patient feel like the impulse, and this impulse stimulates the penetration this solution deeper to the bone. Usually it doesn't work. The idea of the physical therapy is the same, stimulation of macrocirculation. If you use only conservative therapy, it's after 5 days. If you use the combination conservative and surgical, after 5 to 7 days after surgical procedure. Understand what I mean? If, for example, you on Monday fix the splint, but it's not enough because it's not fixed to the right position, you understand it, because a patient lost the teeth, and you're planning on next Monday, for example, osteosynthesis, on Friday. From this time, we wait 5 to 7 days and prescribe physiotherapy. What about the jaw diet? Patient cannot eat, cannot drink. What we prescribe? The patient use like a smoothie, the consistent of the food, and the very interesting how to patient eat. They use small spoon and fix the smoothie, for example, to the distal part, and it's like when you put the ice cream inside, and it's like this one. Understand what I mean? Because patient cannot move normally because it doesn't open the jaw. The mouth cannot open, and the tongue cannot movements. And this is the real problem, because if the patient if the patient has a fracture, patient for months lost the weight about 8 to 10 kilograms. Sometimes it's huge, especially if the patient weighs about 47 kilograms, minus 10, it's about 40. It's the huge. If we understand that the patient has big weight and patient lost weight 100% from 7 to 10 kilograms for 1 month, we can use a special proteins cocktails with proteins, like for food, because patient cannot eat typically food like was previous. Jaw diet, we have some types of jaw diet. What does it mean? If the patient, you know that from the general medicine, we have a special diet type. It depends. Patient has systemic diseases in gastrointestinal tract, for example, ulcers, or has, I don't know, maybe problems with renals, maybe problems cannot eat something. And we have 12 types of diet. And these types depends where problems. In maxillofacial region, we can use first and the second type of diet. What does it mean? It's absolutely soft, and the structure of the food, it's the room temperature, not cold, not hot, and the structure, it's light viscosity, and it's really looks like smoothie. It's blended and melted, that the patient can eat. Probe feeding methodology. It depends on the single, multiply types of the combination trauma. For example, if it combined with the extraoral injuries, sometimes if patient in the intensive care therapy, they use a special intranasal intranasal probe, and they have a special intranasal diet when without oral cavity. You know that we have the communication between the throat from the nose, you know it, and we use this type of diet. If the patient can move, no need for intensive care, we can use one and second type of the diet. Here, intranasal. Feeding the patient from the drinking cup, yes. If the patient has a limitation of position, what does it mean? Has not typical position. For example, patient has a fracture, and the water is very important to save the normal macrocirculation of the electrolytic balance. And who can drink the patient? It's the nurse seat. We have a special cup with long, it looks like just a second, I forgot the name of these words.
True?
Just a second. It's like watering can. I mean, it looks like with long part, like a tube, and the nurse fix the tube between the buccal part of the teeth and the cheek, and fix it deeper, and patient can drink. Patient change the direction like this to this part will be from this side, and change the patient change the configuration to the adjacent to the, this is the right, this is to the left, change the direction of the head to the different side, and the nurse put the water or the solution like a small portion. It looks like this one, like a pump. It's like a pump. Yes, it's like a pump, like a pump. That's this is speciality of the care, because the patient stay at the maxillofacial surgery department. This is the big problem, because you know that sometimes we have many patients with the trauma. Now we have patients with the huge trauma after the war and need a special care for the patient. What is the reason if the patient cannot cannot brush the teeth? What do you think? Why we need to use oral hygiene, guys, if the patient has fracture?
Because the patient can't open the mouth, and we have the acid, pH acid, I think.
Maybe from the spelling
bacteria and oxidation.
Yes, we can use, we have, or patient has secondary inflammation from normal microflora to the wound area. This is the reason why we need to clean, because especially if it's open type of fracture, you have destroyed of the soft tissues. Of course, you suture it. Of course, if it's possible to suture, yeah? But it's not growing immediately. It will be like a hole, and all microbes penetrate this hole. Why we need to decrease the level of toxicity from the microorganism from the oral cavity. This is the reason why we prescribe we need to use the oral hygiene. It's the first reason. And the second reason, all conservative or surgical treatment has the element who fix on the teeth. They need to fix 4 to 6 weeks, 1.5 months. For 1 month, how many plaque will be? It will be stone. What is stimulus? If it was before deep caries, will be pulpitis, yes, or periodontitis. If the patient fixes the jaw, we cannot open. Impossible to use conservative therapy, endodontical therapy. And the reason of it, we need to remove the normal tooth, because no oral hygiene, if no oral hygiene present changes the level of destroyed the hard structure of the tooth, then it's penetrated deeper and stimulates the inflammation. We can have inflammation in the area where present the fractured line is the first, or changes the level of deeper. It may be around the fracture or going deeper, and maybe stimulates the abscess of ligmon in the area where was fracture. It's the first, or maybe stimulates what the diseases we discussed in last semester, or osteomyelitis. Yes, but this is the reason of osteomyelitis will be traumatic, because we destroyed the bone, not we, jaws broken, we have the space, microorganisms penetrate and stimulate the producing the necrosis of the bone. This is the reason why we need to care about the patient with maxillofacial trauma, especially if it combination trauma, especially if it will be like this. And next one is the prophylaxis of inflammation of complication after fracture.
So doctor, we have a question like
Doctor, in which case we use bone grafting?
Only when it possible. We have many bone grafting. We don't discuss it on this semester. You need to discuss it. Sorry, I don't have time to discuss it.
Okay.
I'm مذاكر اللي علينا. Doctor 33 like splints with extra or attachment to plaster cap.
Yes, you have the information about the upper jaw in the portal. I download all information about the upper jaw in the
We only
file.
have like general principle for treatment and some tests.
No, you have the therapeutic methods of reposition. 33 question.
33, yes.
You have the therapeutic methods permanent. It's like a conservative therapy, the same. Splinting technique. It's this. We can use it for the upper jaw.
Yes, but with extra or attachment to plaster cap. What is the meaning?
This is the same like compression distraction of the osteosynthesis. It's the same. But we prefer dental splints. We can discuss that it's possible with extra oral attachment. If, for example, after trauma was huge defect, patient, for example, was a car accident and was the big trauma and the patient lost part of the jaw, of the upper jaw. I mean, for example, if it will be LeFor 2 middle type and the fracture of the maxillary sinus and patient lost the wall of the maxillary sinus and huge defect, for example, no bone there. We can use the compression distraction osteosynthesis. It's the same name, like extra oral attachment plaster cup. It's the same. If the patient, for example, lost the zygomatic bone, what we should do? What do you think? If the patient lost the zygomatic bone, was car accident, the patient lost the zygomatic bone. They absolutely destroyed. If you remember the thickness of the zygomatic bone, it's too thin. Yes? What we should do? We use the special technique for reconstruction from the plastic. It's the name of this implantation, but it's not the dental implantation. It's the reconstruction with the artificial implant from plastic material to fix it and create the new zygomatic bone. We can use the same technique if the patient lost the wall of the jaw. For example, no maxillary wall, no vestibular wall of the maxillary sinus when the present fracture of the upper jaw. We can fix it, create this space, but it will be never bone. You create only the shape. Yes, it not will be the bone. It will be only shape. We can use the same extra oral attachment if the patient lost, for example, part of the, for example, occipital part or frontal part of the jaw. We can use the special technique to fix it and cover it. No function, only view. Understand what I mean? With artificial material, with the plastic. Now you know that we can use which type of technique. You know that we have a special tissue printer. You know it, yes? We have a special printer who creates the part. What we use? We use the MRI to scan, if no, this wall. In special program, we use the shape from the normal size. If we don't have, we create it in special program. We know the defect. We know on the program how many we need. We print it and fix. This is the extra oral attachment. Understand it?
Yes.
Doctor, what is the healing time of the osteosynthesis in the lower jaw?
I can ask you. No, you ask me.
1 month, more, about six weeks or what?
It depends from what we discussed it on the classes. It depends how many lines of the fracture, how many periods of bone regeneration you know, normal regeneration of the bone. How regenerate the bone?
It's from 2 to 3 months.
How many periods of regeneration do you know?
You know about the capsule of the fibrosis?
How many days present capsula?
About from 4 weeks maybe? 4 weeks?
Doctor, do you mean when we have cartilage, then the young bone, then?
Yes, and this is the type of regeneration or the process of physiological regeneration of the fractured bone. But if we have single part of the fracture, single fracture, when we have two fractured lines and no osteosynthesis, the time is shorter. Understand what I mean? But it's not shorter or smaller than 1.5 months, because first create the new cartilage, then new bone formation, then adult bone. Normal bone in the area of the fractured line, who said 3.5 months?
Yes, 2 to 3 months.
Yes, usually 3.5, two smaller, 3 or 3.5. What does it mean? If we can take the histological cells from the line of fracture, it will be the same like in the area where no fracture. Understand what I mean? We have two parts of the bone, cortical and spongious bone. Spongious bone growing, how growing?
2 to 3 weeks.
No. I mean, what
Fast.
faster? Cortical
Sponges fast.
spongious faster. Then forming the shape of cortical plate. Cortical plate finished to growing after 3.5 months. It's the upper or lower jaw. Where faster, upper or lower jaw?
Upper jaw.
Upper jaw. Because massive spongious bone and thin cortical plate. For the lower jaw, we need more time, 4.5 times, because it's one thick nerves, the same one vessels, and the cortical plate thicker than the spongious bone. Need more time for mineralization. Right mineralization, the level of the bone. If we have two levels of the fracture, for example, from the both sides of angle, from the mandible, near the angle or near the mental foramen, how many months will be regenerate the area? Because we have two lines of fractured bones. How many?
8 months.
3.5 plus 50% of normal regeneration, about
5 months.
5 months. If we have multiplied areas of the fractured lines, how many? About, sometimes it's about
1 year.
1 year, yes. Do you remember what we discussed? How we understood that possible to use this place of the bone where was fractured for surgical procedure. I mean, how to understand? We can use 3 times of X-ray. In the time when you see first patient, after the splinting or after the surgical procedure, and after 4.5 weeks, 28 to 35 days, we need to take another type of X-ray. Then we wait 3.5 months, it will be first time. Patient with fracture will be on regulation checkup. 1 month, 3 months, 5 months, 7 and or 6 if you want, 7 and 1 year. How to explain the patient, why we need to check the patient, why we need to see the patient and check, to understand the level of mineralization and to check the structures around the fractured line. Sometimes what happened, after 1.5 months, start the periodontitis. The sensitivity on the area where was fracture decrease like normally, and patient cannot feel normally the area around the fractured line. Long time, sometimes no sensitivity more than 5 months after reposition or after osteosynthesis. We need to check the patient because sometimes start the acute periodontitis. If acute periodontitis will be around the area where was fracture, what will be the complication? Acute, odontogenic, osteomalacia. Why we need to check the patient? To control the process of regeneration and control the teeth around where was fracture. This is the reason why we need to check the patient. And how to understand yourself, thus, for example, if was fracture in the angle, you know that patient has horizontal retention of the wisdom tooth on the lower jaw. How to planning the tooth extraction? We need to understand finished bone regeneration or no. How to understand? We need to check on X-ray because you remember the procedure. How to remove the wisdom horizontal retention teeth? We use the cut, then we drill the bone, yes, to open. Then we separate the part of the crown, separate the root, and using the pressure. Possible to use this technique now, or we can wait more time.
Wait more time.
How to understand on X-ray? Yes. Usually, if was fracture on the angle of the lower jaw, and you're planning to remove the wisdom horizontal retention tooth, you're planning after only if after 1 year after tooth extraction. Because the process of mineralization and osteogenesis not finished now. We need to waste more time. Understand?
Doctor, but if we have access to remove the wisdom teeth, it's not better that we do it in the same time of incision as you told?
You mean fracture or abscess?
No, abscess. About abscess now.
If it's odontogenic reason of this abscess of ligmon, we need to remove the causing tooth as soon as possible. Ideally, in the same time where was the operation, where was the incision, where was the operative access, in the same time of operation. If patient has limitation of the mouth opening, cannot open to fix the elevator, to fix the instrument, not enough space, yes, in oral cavity, we wait the time when patient can open the mouth. How to check it? Usually 3 to 5 days after operation, but idea tooth extraction as soon as possible. We cannot, if you cannot save the tooth, and the tooth the reason of odontogenic abscess and phlegmon, impossible to conservative treatment. We need to remove the causing tooth. It's the rule.
Okay, doctor, number 40, the last question. Again, there is no material about this.
Kirchner spoke as osteosynthesis with a single with single screw. It's not the screw, because screw has direction, and this is the Kirchner's fractured. Guys, sorry, I'm tired. The time is 9. I can speak. Sorry.
Doctor, sorry. What about the cases? It's most important.
I know,
things
but
that to us.
we discuss 2 hours. Now it's 9. I don't
just
have...
if you have the file, doctor, you can send it to us without any.
Yeah, we need to read them, please.
Just we can read it with.
You know that today it's not the day about the discussion. Natalia Viktorovna, especially training my brain and asking me that you don't have enough time. In my position for this, you have a time for consultation in Friday. Now is 9. We discuss more than 50% of questions, guys. I understand you, but you understand me too. Which type of case, what we need to discuss? We discuss in practical classes some case. What you need to discuss else? It will be typical clinical situation picture. Patient with pain, with swelling, cannot open. What you can see extra intraorally. How to diagnose? Which type of additional treatment you need to use, or additional diagnostical test and operative access. You have only abscess and phlegmona and the fracture. Clinical picture. If you understand the clinical picture, I mean the clinic of the abscess and phlegmon and the clinic of the fracture, it's no problem for you to answer.
We're just afraid about exam only, doctor, so that we need this clinical case.
I have only examination case. I cannot send you examination case.
So and just explain about how it will be, doctor, in only 1 minute.
We discussed it. We have in the first course exam on winter session, you have question and clinical situation task. What's the don't understand?
Only we need to train about this clinical case or examination call, like.
We discuss how many questions now.
Not questions. I am asking about the task, the clinical case.
9 o'clock at evening.
Doctor, but a Russian group takes the cases before the exams.
And what? We discussed the examination on practical classes.
No, they took already the file before the exam to read it.
Where is can find it to read? Tell me, please.
Doctor, but
where is the guys from the Russian students find the files about the examination task? Tell me, please.
Doctor, about the group A3, we didn't take any class.
Yes, you have the material for preparing.
But what about the cases? You said you explained in the class.
Guys, what you want from me now? 9 o'clock at evening.
Nothing, doctor.
Okay, doctor, good night.
Go, doctor, you can go relax.
Good luck, have a good night.
Have a good day.
Thank you.
Have a good day. See you next day. Thank you.